So thank you very much for the organizing committee for the invitation. It's a great pleasure for me to be here today and to discuss with this very easy topic. This is a joke, of course, for patients without a driver, without a PD-L1, that of course is not the best setting for all of us in clinical situation. So this is my disclosure. So I get you to the premise. So it's very difficult in clinical setting when we consider patient with a lung cancer, consider in the real evaluation of a future perspective, patient with a PD-L1 negative. So it's very easy to discuss a patient with a driver mutation with a lot of TKIs approved in clinical setting. And also for patient with a long-term survival when achieved with the use of PD-L1 expression. But the patient with the PD-L1 negative evaluation in clinical setting, having about 30% of all our patients that we are generally able to treat. And this is very not easy to understand the long-term evaluation compared to different kind of trials that show with a very, very long tail of course when we use immunocheckpoint inhibitors. But I think that the point for our comparison is a very, very clear slide of Peter Solange that to focus our need when we treat patients with lung cancer. In my opinion, when we treat a patient with a negative PD-L1. And the problem, of course, is the comparison with patients with a high PD-L1 expression. In clinical setting, a lot of patients we treat with high PD-L1 expression and also in different kind of trials show a very long survival when the PD-L1 is more than 50%. But we know that PD-L1 more than 50%, of course, achieve a lot of increase in survival. And this, of course, is the major problem when we compare patients with PD-L1 low in clinical setting. And a different kind of trial in the past years, and not in the last years, evaluated the role of immunocheckpoint inhibitors alone in patients with a PD-L1 negative, and the results was not so strong to show a benefit over the chemotherapy. And the trial that changed the perspective and changed the view for this kind of patient was the Keynote 042 that evaluated the use of PD-L1 inhibitors, pembrolizumab, about patients regardless of the PD-L1 expression, in PD-L1 more than 50%, in PD-L1 intermediate, and PD-L1 negative. And for patients with the PD-L1 low, we can see that there is a crops Kaplan-Meier and about in the first 3, 4, 6 months. And this, of course, is a limitation, the big limitation in clinical setting more than in clinical trial when we are evaluating, we are treating patients with the PD-L1 negative. And of course, the future, when we see the past of the trial with the immunocheckpoint inhibitor, in particular patient with low PD-L1, was the use of the combination of chemo plus immunocheckpoint inhibitors. And of course, here the hallmarks of IO combo is not only the long-term benefit, but in particular also the treatment response, the treatment-free survival, and also the safety profile that we'll discuss later during the presentation. A lot of trials discuss the combo of chemo plus IO with the anti-PD-1, anti-PD-L1, and also anti-PD-L1 plus GTNL4, and the benefit, as we saw also in the previous presentation, is also strong for patients regardless of the PD-L1. And this is clear for patients with a non-squamous histology and also for patients with a squamous histology. But we know, and this is a very clear summary of the two most famous trial that evaluated the combo of chemo plus IO, that for patients with a PD-L1 negative, the long-term benefit, of course, is very, very limited. And in particular, this is very, very not consistent for patients with squamous disease. But in a pooled analysis that was performed by the colleagues of the different kind of trial that include only patients with a PD-L1 negative, we can see that we're seeing a very clear benefit also in progression-free survival. And this is not related to the numerical improvement in 1 month, but in particular to the improvement, to the reduced rate progression in the first 3 months of treatment. And this, of course, is a very, very clear for patients with PD-L1 negative that was evaluated according to the overall survival. This, of course, is not a great explanation that the patient with PD-L1 negative achieve a long overall survival when we treat it with a combo of chemo plus immunocheckpoint inhibitors. And the problem, of course, is when we look through the data, for patients with a PD-L1 negative across two different kinds of trials. In this trial, the Empower Lung 3, that was a very similar trial to the Keynote, the companion chemo plus platinum-based chemo plus cemiplimab, we can see that for PFS and in particular for OS, we have no benefit for patients with a PD-L1 negative disease. And this, of course, is a key topic in clinical setting. But of course, we do not consider only PFS and OS, but also the response that was stronger for patients with a PD-L1 negative. But I think that the history of patients with a PD-L1 negative achieve a significant push when we look through the back for patients that was enrolled in the trial that evaluate also not only PD-L1 chemo, but also the use of anti-CTLA-4. And this is evaluation of the Kaplan-Meier curves of the Checkmate 227, that was a trial that did not change the clinical practice, in particular in European countries, according to the approvals. But we can see that for patients with a negative PD-L1 cohort, we can see a long-term benefit for those patients that was a candidate to receive the combination of Nivo plus Ipi. And this, of course, was consistent across the histology for patients with squamous and non-squamous disease. It was, of course, the backbone to the evaluation of the new trial, the Checkmate 994, that was discussing very, very deeply in the previous presentation. The Checkmate 994 was born from the idea that maybe we can reduce the number of cycles of chemo in patients that was enrolling in Keynote 189 and Keynote 407, considering the very important need was in the first 3 months of treatment when there was a decrease in patients in the Kaplan-Meier curves. And this, in this trial, we can see that the chemo cycle was only 2 with the platinum-based chemo, with the Nivo and ipilimumab with a different dose of the melanoma trial. The control arm was a chemotherapy with a 4th cycle of platinum pemetrexed or platinum according to the histology. We can see that the benefit was consistent for patients with a PD-L1 positive and PD-L1 negative, but it's very, very interesting. Look the data of the overall survival, and considering that these subgroups are based on a very limited number that are not very easy to compare, we can see that the benefit in patients with a negative PD-L1 is very consistent and very strong compared also to the other Kaplan-Meier curves. And this is also very interesting. And move to the last trial that evaluated the combination of CTLA-4 plus another anti-PD-1 inhibitor and chemo, that was the Poseidon trial. Is a very strong phase 3 trial at the beginning in the 3 arms that then showed only 2 arms that evaluate a 4-cycle chemo plus a double immunocheckpoint inhibition compared to standard chemotherapy. And also in this trial, we can see that in patients with a negative PD-L1, we can see a trend in favor for the combination with anti-CTLA-4. Of course, these are not robust subgroups analysis, but of course is an important signal that we need to consider. Consider that at the present time, we have a very high number of trials that evaluate the combination of chemo plus IO and show always the same situation with a limited benefit for patients with PD-L1 negative when we consider chemo plus PD-L1 or PD-L1 inhibitors. And this benefit is stronger when we have the CTLA-4. Of course, it's very, very difficult. It's not easy to make an indirect comparison of a very important phase 3 trial, but the signal, of course, at the present time, and we have no long-term data from the Poseidon trial, is that when we had a CTLA-4, maybe the additional overall survival is better for patients with PD-L1 negative. And maybe in this particular room, the use of the anti-CTLA-4 combo, the Checkmate 9LA or the Poseidon combination could be considered as the best standard for patients in clinical setting. Of course, these data are not so robust and not so strong in clinical setting, but the future is trying to move different kind of combination And this is a slide that was developed by Solange Peters with the new combination that are ready to be presented the next 2 years. So we can see that the combination of chemo plus IO will be maybe changed with the addition of PARP inhibitor or VEGFR inhibitors that show with a very, very interesting presignal in clinical setting, and confirm that in patients with a PD-L1 negative and PD-L1 not more than 50%, and now the standard of care should be considered chemo plus immune checkpoint inhibitors, but the addition anti-CTLA-4 should be considered in clinical setting as an option for our patients. Thank you very much for your attention.